As Marina said, what I'm going to talk about is services attended by children in waves 1 and 2. So I'm including both waves, or both waves that we have data for at the moment, and barriers to services, access for children, and some issues around support to carers, and the factors influencing support. So why is this an issue? Other than the actual provision of care, service provision is the most important component of the care experience, supporting the child's well-being. Children in care typically have access to a wide range of different services, and the carers themselves also access services, both informal and formal support services. And then a particular service that we're focusing on in the analysis, although I'm not going to present much about it, is casework support for the carer and for the child. And when we get into the longitudinal analysis, we'll be able to look at the effectiveness of casework, both in terms of caseworkers as access to other services, but also the effect of the caseworker, hopefully, on the well-being of the child. And this answers the key research question: what are the placement and service intervention and case planning pathways for children during their stay in out-of-home care? So just to give the kind of context, this slide talks about the vulnerability of children, and basically about a third of the children have some kind of vulnerability or other. So Paul's talked a bit more about that, so I won't go into that in detail. And this slide gives you a little bit more detail. Those of you at the back won't be able to read it, but these are the range of conditions at wave 1 that children are subject to. And you'll see that developmental delay and cognitive and language and asthma are the two highest. And then it goes down from there. Now we're getting into, so those are the conditions, these are the services that the access to address those conditions. Firstly, by demographics, and you'll see that Aboriginal children actually have higher numbers of services. So this is not about, the question asked is, have you attended the following services in the past, I think it's year, 6 months. So it's not about how many times you've been to the physiotherapist or the speech therapist. So it's just, have you been to one or not? And so this is a count of the number of different types of services, and Aboriginal children have slightly more services, and children aged 3 to 6 years have more access to services than children of other age groups in the cohort. Now we're looking at both wave 1 and wave 2 by whether they have a vulnerability or not. And you'll see that children that do have vulnerability, as would be expected, have higher numbers of services that they access. But again, it doesn't talk about intensity of service nor quality of service, which a lot of people ask about, but unfortunately we don't have any data at the moment about the quality of the services that they attend. We didn't do analysis by Western region, but we did look at urban versus non-urban. And interestingly enough, the non-urban placements have slightly more services that they access, but hold that in mind when I get to the end of my presentation, because there's a caveat there. And then the service type, there's a significant difference between foster and kinship carers. So kinship carers have a much lower access to services than foster carers. And this is just the types of services attended, either in wave 1 or 2. GPs and dentists and pediatricians are the highest. And then what's interesting is the fourth highest emergency department is quite high. So quite a high proportion attend EDs, which would be very unusual in the population as a whole, I would have thought. I don't have the figures for it. This is the change in service attendance between the two waves. The green dots are more in wave 2, and the orange dots are less in wave 2 than wave 1. So they go to more dentists, more speech pathologists, and more behavioral management services as they progress through the care system, but fewer Aboriginal medical service, well, that's about the same, fewer hospitals and counsellors, etc. But this is partly a factor of children aging as they go through care as well. So obviously the type of service they will attend is going to be different as they age, as well as they go through care. Nearly a quarter of respondents indicated that there was at least one barrier preventing service access. If you look at this by location, then children in rural or non-urban placements are significantly more likely to face barriers to accessing service. And you'll see the huge barrier is waiting lists in rural areas compared to urban areas. But in all those dimensions of barriers, rural areas are greater. So remember I said before that they access more services, but they actually face more barriers accessing those services, which I guess indicates that carers in rural areas are working much harder on behalf of their children to get to those services. And obviously there's policy implications of that. This slide basically says the more vulnerabilities they've got, the more services they access, which is again what you would be expected, and the more barriers the more vulnerabilities, the more barriers they access, and particularly with waiting lists, huge difference. So children with high vulnerability have massive problems accessing services, and that's probably because they're accessing specialist services where there are long waiting lists. So now I'm going to just talk very briefly about support for carers. And this is the contact with caseworkers as children progress. And you'll see, firstly, that foster carers have much more contact with caseworkers than kinship carers, and that increases, so their contact increases more between the two waves than kinship carers. Now, what we don't know, because anecdotally we know that some kinship carers choose not to have contact with caseworkers, so whether they choose or don't choose, we don't know from this question, but certainly they have a lot less. Similarly, though, if you look at the satisfaction, foster carers are much more satisfied with their contact with carers. What we did find in wave 1 was that if kinship carers have contact with caseworkers, if they don't have contact, they're equal, so both foster and kinship carers. But once they do have contact, foster carers tend to be more satisfied than kinship carers. And this is similarly satisfaction in casework assistance. Foster carers much more satisfied. So moving on to social support for the carer. The only difference, so this is both foster and kinship carers, there's very little difference between the two waves except for in community organizations where they are able to access more support from community organizations as the child progresses through care. And social, interestingly enough, there's less social support for urban carers than for rural or non-urban carers. And again, that increases slightly. So rural carers have less formal support, but they have more informal support. And that's taking into account being foster carers and the age of the child, etc. Kinship carers have lower levels of social support than foster carers. So we saw before that they have lower level of formal support. Now we're showing that they have lower level of informal support as well. So kinship carers generally are much more isolated, less supported than foster carers. And overall, we're talking about less support for carers in rural areas, even though there's a bit more informal support in rural areas. Interestingly, the amount of social support that carers reported made no difference to the level of access to services for children in care. So again, we see that even those isolated carers are able to access support for the children, even though they themselves are not receiving support. Children with carers that had more caring experience access more service types. So the more experienced the carer was, the more able they were to access services, which is what you would hope. Aboriginal status of the carer made no difference in the number of services accessed by their children. So, in summary, as expected, vulnerable children access more services, and those in urban areas have better access to services. Aboriginal children have a small but significant higher access to services, and placement type has no effect. However, kinship carers have less access to social support and casework support. So there's no difference in the carer type from the point of view of the child, but there's a lot of difference from the point of view of the carer. And rural carers have slightly more social support, but less access to services than those in urban areas. And the next steps, we'll look at service use and placement stability. We're just working out what placement stability actually means, and we will be able to do that analysis. And obviously the ultimate aim of the analysis is to look at the actual well-being of the child and the effect of the service use on the well-being, but we need those three waves in order to do that analysis. And then the link between casework, support, and service use. So we've looked at case satisfaction with a caseworker. What we want to look at is whether that actually makes a difference to the well-being of the child. And that's it. Thank you.